Life expectancy. Why is this an important talk? Life expectancy is not always apparent, and some assessment is absolutely vital for evidence-based guidelines. And this is especially true with treatment options when considering expected management, screening, when do the risks outweigh the benefits, and tracking outcomes. People are living longer, thus current models do not always apply for future population. So things that were applied years ago for a population that may have lived 5 years don't apply for a population now where people may be living 10 years longer after a certain age later in life. Healthcare professionals are generally not very good at estimating life expectancy, and this is a major issue for older patients. Older patients that are there are selected to live longer, and I think people don't always understand this concept. If you look here, healthcare professionals underestimate by 20% in studies years ago, and this is still true, life expectancy of older patients. And that's the population that we're seeing as urologists, people in their 50s, 60s, and 70s. So my lecture outline is, what is life expectancy and how is it defined? What are the different ways to calculate it? What are life expectancy trends in the US, which are really interesting post-COVID? And urologic malignancies, the influence of life expectancy on management, and how changing life expectancy influences outcomes. So life expectancy is the average number of years a newborn is expected to live with current mortality patterns remaining the same. This is not the average age an adult could expect to live. And so the people make the mistake of going, oh, here's Mr. Jones, he's 72, and his life expectancy is 75. Well, that's not it. His life expectancy is actually late 80s if he's fairly healthy at 72, because the life expectancy from birth is not the one you should be looking at later. What are the traditional ways to assess it? Well, this is the formula here that the insurance people use. I don't think this is something we can incorporate into our office, even with the quote, God sent Epic to help us. From a life table, which is the one that we use now, but life table takes age, sex, and race, but does not incorporate comorbidities. And what we're seeing is we're starting to see some areas where there's life tables incorporating some comorbidities in there and ones with self-reported health. And I haven't seen a perfect one, but we're getting better. And in your mind, if you can look at a patient and eyeball them, I think you can usually do a pretty good job of assessing them. This is a life table here, and just to show how long people live. This is the exact age of the patient, and you can see 7 to 70, 74 is a very common age for when we see patients in our office. And a 70-year-old male has a 14-year life expectancy overall. So a 70-year-old male that you're looking at, the odds say that he's going to live to 84. So this concept that a 70-year-old male is going to die in 5 years is so far off. And for women, it's even longer. A 70-year-old woman is expected to live almost 16 years. And so it's clearly, when you're looking at patients and assessing treatment outcomes, you need to have some sort of assessment of this. What are some things that are helpful? This is an interesting paper from the Annals of Internal Medicine. They took a sample of Medicare patients, and they took the 3 most common comorbidities, diabetes, COPD, and CHF. And just in this one study, they were able to show that estimated life expectancy at age 75 years, it was 3 years from the table. So if you took that population, it was 3 years longer for people that did not have significant comorbidities, and it was 3 years less for people who did. And these are not even the most significant comorbidities. If you look at here, this is with a decreasing hazard index, AIDS, cirrhosis, dementia, very important for our patient population. Chronic renal failure, severe liver disease are the ones with the highest possibility to decrease life. And you can see COPD, dialysis, things like that are lower down. But anyway, it just gives you an idea of how somebody who, in general, you look at the life table, somebody who has multiple comorbidities is going to obviously live less long, and people with no comorbidities are going to live significantly longer. And that's why we're seeing a lot of people walking in, 90 years old, came off the ski slopes from Jackson, and go, can you do my PSA screening? Life expectancy, this is very interesting. We had years of steady increase due to improvement in death rates due to decrease in cardiovascular disease. And most of this was actually smoking cessation. Smoking cessation had a huge impact on life expectancy in America. Other factors would improve care. But recently, as you can see from the tables, we have a decrease in life expectancy. The obvious one is during the COVID years. You can see here, this is life expectancy in America, and it was steadily going up all the way up until 2020, and COVID hit, and you can just see the sharp drop off there. What's concerning to me, especially in this country though, is you can see this is America right here. I mean, this is America right here. So we came up, we had this drop off from COVID, but we never recovered. This is the comparable countries in Europe, and you can see that their life expectancy went down, not as much, and it recovered back to where it was before. So certainly an important trend for our patients is I think we're seeing a lot of obesity, we're seeing a lot of other comorbidities that are starting to jump in there, and it's catching up with us because we're not seeing the bounce back as we would expect in life expectancy. Right now, one of the top 10 causes of death in America, obviously heart disease, number 1. Stroke is number 5. So if you take cardiovascular disease, by far it's the most. But you can see cancer is not that far behind cardiovascular disease. If you look here, as we talked about, the risk of death from cardiovascular disease, mostly from smoking and other medical therapies, was 30% from 1997 to 2007. So that's where we saw that big drop. So what's happened is we've decreased the risk of death from heart disease, and now what's number 2 behind heart disease? Cancer. So if you look in 1980, the number of deaths from heart disease is 600,000. Number from cancer is 260,000 in America. In 2019, you can see those numbers are coming together. I mean, disease of heart is 530,000 deaths, and from malignant neoplasm is 430,000. So you're seeing now a higher percentage of patients dying of cancer. An important trend that we're seeing now is patients who used to die of heart disease in their 70s are now living long enough to die of cancer in their 80s. And this is really important for urologic malignancies. When we look at prostate cancer, kidney cancer, things like that, we see patients in their 70s and we're like, oh, well, you'll die of a heart attack, just go live your life and don't worry about this. It's not the case. And I don't know if we'll ever get to the point where cancer goes above cardiovascular disease, because we made such a great stride with smoking. I don't think there's any new smoking to replace that, but it's food for thought when you're thinking about how to assess your patients. How does this relate to urologic cancers and management of which cancers are greatly affected by life expectancy? Well, what is the importance of life expectancy with cancers? Non-cancer life expectancy, in other words, looking at that patient and taking away their cancer risk, is vital when making clinical decisions for current clinical diagnosis, and especially clinical screening for prostate cancer, which we're going to get to later on. So if you look at the most common urologic cancers, urothelial, testis, kidney, prostate, those are the ones we see the most. If what we're going to look at here, just very briefly, but to get you in the mindset, age distribution of the malignancy, the prognosis of the cancer, and the likelihood of causing symptoms requiring treatment regardless of long-term prognosis. So urothelial bladder cancer, it's likely to affect a much older population and is rarely asymptomatic. Almost everyone with upper tract TCC or bladder cancer becomes symptomatic at some point. So it's not like getting a PSA test in somebody or picking up an incidental renal tumor on a stone disease. High-grade stage disease can rapidly progress and lead to cancer-related morbidity and mortality. So getting you in the mindset that when you see bladder cancer, you almost always have to treat it, regardless. The patient may have a 4-year life expectancy, but you have to treat it because they're going to become symptomatic, number 1, or they're going to rapidly progress to metastatic disease, and you don't want to get to that point. And point here, you can see the 5-year survival rates for urinary bladder here. All stages is 77%, but you can see if they have regional metastases or distant disease, their 5-year survival and prognosis is dismal. And so for most cases, you need treat no matter what. And one interesting thing, if you look, autopsy studies show that this malignancy is almost never incidentally discovered. So finding a bladder cancer or urothelial upper tract cancer incidentally is, unlike prostate cancer, is almost never done. Testis cancer, likely to affect younger population, almost all of the significant ones are under 40. Disease progression rapid, not likely to be an incidental finding. And so with few exceptions, this is a cancer that it's really not important. You're gonna, with the young age of diagnosis and aggressive nature, you're gonna treat that no matter what. So this one really isn't in the realm of life expectancy. We're getting into the ones that it really does make a difference here. Kidney cancer, likely to affect an older population. Unlike bladder cancer, commonly asymptomatic, usually discovered as an incidental finding now, usually on cross-sectional imaging for other reasons. And it has varying biologic potential where they have ones that small tumors that rarely progress, but large tumors can follow a much more aggressive course. And life expectancy is a large part of the decision for treatment options, especially when you're looking at active surveillance in older patients. So this is important. If you look here, this is a 5-year survival, ACS for kidney cancer, and you can see for all stages, it's 76%. Pretty good for local disease, 93% overall. But you can see for regional disease and with those with distant metastasis, significant chance of death in a 5-year period. So you really need to look at whether they have a reasonable if they have aggressive disease, they need to be treated probably regardless of life expectancy unless they're on death's door. If they have a less aggressive small tumor, then less. So once again, tumor size and stage very important when making these decisions. Small T1 tumors are highly unlikely to cause problems with 5 years and strongly supports active surveillance in older patients with limited 5 to 10 year life expectancy. Conversely, larger, higher stage tumors have a high chance of progression. These are ones that need to be treated. And I will put in here, unlike prostate cancer that's picked up incidentally, symptomatic tumors, patient with intractable gross hematuria, high stage disease, these are ones that are going to need to be treated regardless because you can't have somebody living with chronic gross hematuria. That's got to be addressed. Prostate cancer, this is the one where it is probably most significant. Why? It's mostly in an older population. It's commonly asymptomatic and symptoms only with advanced disease. Both advanced and local disease have excellent 5-year survival. So unlike somebody with bladder or kidney cancer that has advanced disease who have a high chance of dying of their disease in 5 years, even advanced disease in prostate cancer does not have a significant chance of dying in 5 years. Autopsy data shows this is a common finding in men over 70, so most men are living with it. And so life expectancy is definitely a major factor for treatment and screening. If you look here, this is the ACS 5-year survival, and when you look here, all stages, 98% 5-year survival. So on one hand, it's hard to argue for intervention on something that's going to cause disease, not going to cause problems for 5 years or death, I should say. But this is where life expectancy comes in because 5 years is 5 years, but there's a lot of people who are older that are living a lot more than 5 years, and that's where this comes in. I think this is the most telling study, the European randomized screening trial that was multiple ones that was really, I think, fairly well done. And if you look here, screening versus control, you can see the curves are the same up till 7 years. And you can see here at 7 years, they separate. And so I think a reasonable, in my opinion, way to look at the patients I still screen that have a 7-year reasonable life expectancy. I was just talking to Jerry about this. It doesn't make sense to me why the AUA still says 69 as a cutoff because 69 is not very old for a lot of patients in today's society, number one. The American Cancer Society recommendation is at 10 years, which I think is more reasonable, but once again, you can see there's a separation of the curves at 7 to 10 years. So my personal opinion is patients should have a 7-year life expectancy to see the survival benefits of prostate cancer screening. And it may not be a lot of cases. We're talking of order of single digits, but when you have something that's so prevalent, those single digits for something that's prevalent is significant. And if you look, prostate cancer is still the number 2 cause of cancer deaths in men. So just for the sheer numbers, there's a lot of people there. Patients diagnosed with prostate cancer screening, short life expectancy, are highly unlikely to see the benefits and will have worse quality of life as a result. So people that less than 7 to 10 years, these are people you really need to back off on. The biopsies, the treatments, you're going to cause more problems in most cases than you're helping. But people with medium and long-term quality of life may be improved with screening. And the big thing that we're seeing now is the prevention of advanced disease. In conclusion, life expectancy rather than chronological age should be used assessing the cancer patient. Life expectancy is not always readily apparent, and except for COVID pandemic have been steadily increasing for decades in this country. Physicians tend to underestimate the life expectancy of older patients. There are multiple ways to assess, but life tables are useful tools, especially when you take life tables in conjunction with comorbidities, and hopefully we'll come out with better, easy ways to do that assessment. And clinicians should consider interventions by comparing the risk of the disease progression, morbidity, and mortality with reasonable life expectancy. I just want to present 2 cases here that I think typify this. Case 1 is a 75-year-old male presented in 1998 with a PSA of 2.6, 4.05 over a 3-year period. PSA was done strongly against the advice of his primary care. Past medical history is unremarkable. Family history, parents lived to 96 and 92, and one of them was a smoker. Biopsy 5 course, 4+3, recommended radiation, but decided on radical prostatectomy. Path was organ defined, NED for 24 years, died in 2023 at the age of 99, okay? Clearly something, and interesting, patient went to Hopkins and he was recommended not to have treatment by Bal Carter. Case number 2. 92-year-old male presents in September of 2022 with 3-month history of weight loss and hip pain. Prior to this, 6 months before, was riding a bike 12 miles a day, told to stop PSA testing at age 72. Past medical history, none. Father lived to 102, mother to 96. He presented with a PSA of 2600, biopsy all cores, Gleason 7 and 8. Diffuse metastatic disease, responded to hormone therapy, is now in home hospice. Well, these are the patients. This is my dad, died last year in 99. And so obviously if we had, we say this doesn't affect people and just cut off PSA screening. And had he listened to his internist, his quality of life to 99 would not have been good. He died at 99, he hit his head and had a subdural and died in a week, and it was a reasonable way to go. This other person here is my father-in-law, who was told by his internist, despite the fact that he had relatives living to over 190s, and he's in hospice right now. This was us hiking out in Rock Creek Park 2 years ago. So this does affect, this does affect people, and it's not, people are not numbers, and as I said, we're talking to Europe, they don't even let you PSA screen after certain years. And I think we got to get more in the mindset of what is your life expectancy in front of you, not many years you have behind you. Thank you very much.